We'd like to get started. We're running a couple of minutes late, but we do appreciate everybody who's been coming in, and we know that there will be a few more folks straggling in. For those of you who don't know me, I am Joseph Glazer, President and CEO of the Mental Health Association in New York State, and I'd like to start off by acknowledging a number of the folks who have made this event possible. First and foremost, I would like to thank David Kellogg, who is our Director of Public Policy for the Mental Health Association, who conceived initially of this idea and has worked it through to its fruition, and I am very proud of the work that he has done. I'd also like to thank our colleagues in sponsoring this. We were able and pleased to get sponsorship from organizations who have recognized the importance of this issue. Among them are the Catholic Conference, who has done a great deal of work in addressing the issues of conditions for people living with mental illnesses who are trapped in our criminal justice system. Our colleagues at NAMI, who have done a great job in helping their own community, the families of people living with mental illnesses, begin to deal with what happens to an individual living with mental illness when they encounter the criminal justice system. Also, our colleagues at the Civil Service Employees Association, who you may not know, but they do represent a large number of people who are working in our local jails, serving our community and seeing what happens to folks living with mental illnesses when they get trapped inside our criminal justice system. I appreciate the efforts and the support of all of them and want to thank them for joining with us to make this event possible. Just a few brief remarks, and then I will introduce the other sponsor of this event, Assemblyman Brennan, who chairs the Mental Health Committee, who has done an awful lot on this issue already. Nearly a year ago, the Mental Health Association in New York State became acutely aware of the dangerous situation that is occurring when issues of mental health intersect with the criminal justice system. On June 28, 1999, an individual by the name of Gregory Lee Richardson, a 42-year-old man living with schizophrenia, died while in the Albany County Jail. He was in the jail for 18 days for traffic-related offenses. And while he was in jail, his condition deteriorated. Our role in this has not been about pointing blame. There's been enough of that has gone on already. Our role in this as an organization and that of our colleagues is to do whatever we can to ensure that situations like that cease to exist. Since then, we are learning more about the lives of people living with mental illnesses trapped in our jails and prisons. Deinstitutionalization, a very humane effort to improve conditions for people in psychiatric hospitals, taking people out of the psychiatric hospital system and returning them to community-based care, has led to a situation that is the result, in many ways, of the absence of that community-based care. It has led to what we call trans-institutionalization, the moving of a population from one institutional setting to another. In 1955, according to national statistics, there were 559,000 people living in state psychiatric hospitals across the nation. Those 559,000 people were 0.3% of the population of this nation at that time. In 1998, according to the Federal Department of Justice in a report they issued last year, in 1998 there were 830,000 people living with mental illnesses in prison, jails, probation, or parole. That 830,000 people is 0.3% of the population of this nation in 1998. A specific portion of the population of this country has been shifted from the psychiatric hospital system through the communities, usually by way of the streets, and into jails. We're here today to hear from experts about these issues, begin looking at options to change this. I wish to thank our guests, whom I will be introducing individually, for taking the time to share what they have experienced and the knowledge that they have, so that we can move forward together. Following these presentations, there will be a panel discussion, and if time permits, we will take some questions from the audience. Now I'd like to introduce and thank Assemblyman Jim Brennan, who is a very, very good friend of the mental health community. Assemblyman Brennan is chair of the Mental Health Committee. Started earlier this year by organizing among his colleagues public hearings on this subject in New York City. And we have had, since that time, we have had an ongoing work group with nearly 20 organizations from around the state working together under the direction and guidance of the Assemblyman's office to find some answers to these questions. And I personally want to thank the Assemblyman for what he has done and welcome him in giving some opening remarks. Thank you.
Good morning, everybody, and thanks for coming. This is an important subject to address, and I wanted to thank Joe Glazer and the Mental Health Association for helping to organize today's event, as well as the other co-sponsors, NAMI, CSEA, Catholic Conference, Channel 69. Can't go without them, right? By the way, I'm not James Brennan from a local TV anchor, or former local TV anchor. Joe did mention that NAMI, through its national organizations as well as its local affiliates here in New York, has done a lot of work on this issue for many years, and I want to compliment them for the things that they have done. And you have a very distinguished panel who can offer a great deal of insight and experience as far as mental health and the criminal justice system are concerned. But I just want to let you know that over the past couple of years, my office and the Assembly staff have been doing a lot of touring of prisons and jails as far as their mental health services are concerned, meeting with providers of service, meeting with local government agencies, and conducting our public hearings to try to gain more insight into the issue of mental health and criminal justice. This year in the state budget, the State Office of Mental Health is clearly getting some additional forensic resources, some of the money in case management and housing, discharge planning, some of the facilities that will be built on the campuses of the state psychiatric hospitals, some additional housing. All of this will help us continue to move forward in the area of mental health and criminal justice. But I think what's lacking in this area is a broad systemic effort to deal with this, to put the resources necessary to deal with so many thousands of mentally ill people constantly involved in the criminal justice system, many for extremely minor crimes, and the lack of aftercare services and the lack of other resources available to them that would decrease recidivism, would benefit them, their families, as well as the entire public in terms of whether it's public safety or public expense when the criminal justice system becomes the last option available for dealing with someone with a serious and persistent mental illness. The session is only going to last a couple more weeks here in Albany, and then we're going to be going home. But our work is going to continue off session, and if I'm fortunate enough to return next year and be in this position, I want to pledge to you that we're going to continue to try to work on this issue, try to look at legislation, look at diversion efforts, work with OCA, OMH, local government agencies, as well as many of these experts who are involved with you and advocacy organizations to try to better the lives of mentally ill persons and work to improve our system. Our society can do this. Our society can address this issue. We have the resources. It's just a question of the will and the willingness to acknowledge this problem and bring it to a high level of attention as far as the leadership of our state is concerned. And for that reason, I want to thank you once again for putting this together. So thank you very much.
Thank you, Assemblyman. Our speakers today will be Bert Pepper, MD, Saul Rockler, Nahama Bronner, PhD, and Catherine Abate, and I will be introducing all of them individually. Our first speaker is going to be Bert Pepper, who is a psychiatrist and nationally recognized expert on the criminalization of mental illness. We've had Dr. Pepper speak across our network and the Mental Health Association network. He joined us for our legislative conference earlier this year, and I know that he's continuing to work within our network. I believe in short order he will be with the MHA in Nassau County. The information that he has is very, very important because what it does is it tells us how we got to where we are today. Without further ado, Dr. Pepper. Thank you.
Thank you very much. Thank you very much, Joe and David Kellogg, Senator Brennan, and panelists. It's nice to be back in Albany again. I used to almost live here. Before I begin, I just want to mention that the Substance Abuse and Mental Health Services Administration held a consensus conference of 144 national experts on what to do about people with mental illness and substance abuse about 6 years ago, and they hired me to write a book about the conference proceedings, which I did. This is it. And it only took them 4 years to publish it because of the controversy aroused by some of the recommendations, which were basically that since people with mental illness usually have a substance abuse problem today if they're seriously mentally ill and are often in the criminal justice system, that the providers of services should be able to blend funding from various sources in order to provide comprehensive and integrated treatment services. That recommendation delayed the publication for years. If anybody's interested in a free copy of this, you'll find on the table as you leave that 5x8 sheet of brightly colored paper, which will tell you how to fax a request that will get you a free copy, and the panelists will get their copy today because I brought copies for them. And there's a chapter on the criminalization of the mentally ill and a lot of the data that I'll be presenting today. I'm going to cover the criminalization by first talking about what's happened to our systems of care in the United States, because we've undergone a series of sea changes and we're in the process of reinventing old square wheels. For example, there's a big buzz about drug courts, and some people have already come to realize that the major limitation of drug courts is that the majority of drug addicts are mentally ill, and drug courts don't deal with that. So now we need dual diagnosis courts or MICA courts to replace drug courts, which are obsolete before they got started because of a lack of historical awareness of what's been going on to the mentally ill and to substance abusers in the last several decades. The consequence of social changes has been that we now have in this country several million young men and women who, by their behavior, have earned tickets of admission to jails, prisons, hospital emergency rooms, residences for the mentally ill, community mental health centers, drug rehab programs. The problem is that not any one of those programs alone can either meet the needs of that individual or protect the community from what that individual does when they're drug seeking or money seeking. And so we have a consequence of multi-system failure and people who can get into the hospital or the jail or the emergency room whenever they want to because they carry these tickets of admission in their pocket. But it doesn't do any good. So we have a failed system right now. The biggest numbers I can show you are these. In 1955, the country had over 500,000 public hospital psychiatric beds. We have 60,000 left. And that loss is made even greater by the fact that in those 4 decades, the population of the country has grown from 170 million to 270 million people. So the minimization of the per capita beds for hospitalization essentially means that there is no hospital system anymore in public hospitals in place. Most of those 60,000 beds actually are occupied by forensic crimes in locked units. But the good news is that since everybody has to be someplace, and as the lady in the New Yorker article said, is there no place for me? Society has said, yes, we'll build you a prison cell or a jail cell. And since 1972, we've had a tenfold increase in the number of slots in our correctional residential system, from 200,000 to 2 million, just reached 2 million more. That counts our local jails, our state prisons, and our federal prisons. And pretty clearly, as we squeeze the hospital balloon down, the prison balloon has become even larger than the hospital ever was by fourfold. In New York State, if we look more particularly, we used to have 93,000 public state hospital beds. We have about 6,000 of the 93,000 left. So what have we done with the 93,000 people? We provided some kind of housing for about 23,000. There's about 4,000 in shelters. There are 24,000 of them are homeless. The jails take care of about 13,000, and the state prisons about 23,000. Those estimates are based on the original 93,000. In actuality, the number is probably larger. But those would be conservative estimates of what have we done to the people who we used to put in the state hospital in New York. Now, let me go back in time a little bit and tell you that once this country had integrated treatment for the mentally ill substance abuser who violated society's rules behaviorally, that is, needed correction. And the integrated treatment we had from the founding of Jamestown, Virginia in 1607 until 1790, I call Paradigm 1 the rough justice. That was the integrated program. If you were psychotic, if you were an alcoholic and disturbing people, or if you were a criminal, you were humiliated and beaten in the stocks, or you were flogged in the public square, and if that didn't succeed in correcting you, you were banished, or you were hung, or if you were lucky enough to be in New England and acting peculiarly mentally ill, you could be burnt at the stake as a witch. But it was an integrated system. Everybody got taken care of in one system. Then we started specializing. The paradigm was based on poverty. We didn't have money for institutional care. And then as the country grew, the Philadelphia Quakers said, let's separate out the criminal. And so the first separation from that all-encompassing program was the correctional system, the correctional institution. The Walnut Street Jail was founded in 1790 by the Quakers. It had individual rooms. They gave us the term corrections, which we use today, State Department of Corrections. And their notion was that by meditation, prayer, and education, people who violated society's rules could be corrected and act correctly. However, New York State felt that individual rooms were too expensive, and so by 1820, we founded the Auburn State Prison, which had dormitories and prison industry, two new innovations which were rapidly picked up across the country and became the new model of the correctional paradigm, which gave us our state office building, desks and chairs, and our license plates. Then we had another reform, and a third paradigm was given to us in 1840 when Dorothea Dix said, a lot of the people in those correctional institutions are mentally ill and they need treatment and not correction. And so she petitioned this state legislature, which gave us Utica State Hospital first, and she petitioned Alabama, which gave Bryce Hospital and for the name for the first superintendent. And so from 1840 on, we started building mental hospitals to separate out the mentally ill. And that was a system that grew by buying inexpensive land in the country and sending out teams of patients and doctors to build the hospitals. So from 1850 to 1930, the state hospital was the mental health system. That's what we had. It was easy to get in, as indicated by the hard arrow from the top down, hard to get out because we had no community services. As a result, the state hospital had a one-way valve, and it exploded in terms of population and got up to that over 500,000 people. By 1940-50, we started to realize that we had to have an exit route back to the community, and so New York State pioneered something called aftercare clinics. When I was deputy commissioner in the 60s in New York State, I supervised 10,000 patients in 5 New York State aftercare clinics in New York City alone. When I started in the state system as a psychiatric doctor in Rockland State Hospital in 1960, we already had an aftercare clinic. And let me tell you about the proportion of effort. We had 6,000 patients. We had 42 doctors. 41 of us worked on inpatient service, and the most unpopular doctor in the hospital was assigned to the aftercare clinic. He was assisted by Nurse Ratchet and a German Shepherd for security. But it was a start. We were underway. We were now building a bridge back to the community. Then, in the 1960s, the country changed socially. The 1960s began to break down our love of large, total closed institutions. We got Irving Goffman down from Florida to give us a book called Asylums, explaining that prisons and mental hospitals were all run by the underside of the community, not by the rules on the wall. That inmates and ward aides basically ran these institutions, corrections officers, and that they were not healthy places. There were several other things that in the 60s got us to move towards community and away from large, impersonal institutions. The other major thing that happened in the 60s was that the traditional multi-generational family in the United States began to deconstruct. We started moving from multi-generational families to nuclear families, and by the 70s we had 730 divorces per 1,000 marriages in California. The coasts always lead the way. And then by the 80s we started to have single-parent families predominant in the public system, recipients of services. And by the 90s we arrived at the 2-child, no-parent family, when we had 15, 16, 17-year-old child mothers having babies. And those family changes have had a major impact on all of our public service systems. In the 1970s, the federal government said we should have another route out of the hospital, so we got community support coming from the community, but it never worked with the state hospital aftercare clinics. And by the 90s, we had a total confusion of multiple services going every which way. And yes, we were client-centered by the 90s instead of hospital-centered. However, if the client needed to avail themselves of 5 services, they had to go in 5 directions at once. And that pretty much obtains today. Clients across the state, across the country, tell me that the system is very confusing because of separate operations for different things. Meanwhile, by the 1970s, the drug abuse population had so exploded in the aftermath of Vietnam and World War II that the states were obliged to add a new paradigm. The state operated community-based substance abuse system. We had NAC and we had other agencies. We had to do something about the drugs. The concept then was, let's not build institutions except for Governor Rockefeller. And elsewhere across the country, community-based systems were built. New York State had a brief flirtation with the Oedipus complex around the state. It failed. Those buildings were dumped. And we went into contracting with a variety of drug abuse agencies to provide services. The theory of a seamless, integrated continuum was a theory. It was never a practice. And to this day, we have arguments between drug-free and methadone clinics as to how do we treat addicts. Meanwhile, economic changes by the 1990s, the United States and the state economies had already been revised. Jails and prisons got most of the money. The money from mental hospitals, Veterans Administration hospitals, and substance abuse treatment had been squeezed virtually dry to build correctional institutions. The tenfold increase in slots was not built without a lot of money. What we have now is an attempt to build something called assertive community treatment in our communities under local auspices, and there is now recognition that the ACT team has to deal both with mental illness and substance abuse. So most of the ACT teams have at least added a token substance abuse counselor because they arise from the mental health side. My suggestion is that they also had better add a probation officer as a member of the team. For those clients who are already in the criminal justice system, we want to divert them from institutional jail care. We better figure out a new way of providing some integrated services in the community for the offender who's already in the court system or in jail and needs to come out. What's happened to kids in these decades? Well, we are seeing this population of 2 million people in jails and prisons, the 100,000 in New York State, are basically, by the time somebody else ends up in prison, we have seen multi-system failure. We've seen the family fail. In that particular case, the school failed, social services failed. We've seen the public health system fail, as evidenced by sexually transmitted diseases and AIDS and the rise of tuberculosis again. We've seen drug abuse treatment fail and mental health treatment fail as this person matures into adolescence and young adulthood with psychotic episodes. We see these people then ending up on the street, homeless. Housing agencies aren't able to deal with them, and then they end up in jail, prison, and death. And it was 5 years ago that the gun became the leading cause of death of young men under 25, replacing the automobile. So that's the multi-system failure. The problem now we face as a country is multi-generational continuance of destructive patterns to people and community. As an example, here's an Iowa study that shows that if you ask 1.5 million, nearly 2 million people who don't abuse substances, were you physically abused as a child? 13% say they were. 13% say, I was physically abused as a child. If you ask people who abuse a drug, were you physically abused as a child? 26% say yes. It's double. If you ask people in Iowa who abuse 2 substances, like pot and alcohol, were you abused as a child? 55% say yes. And if you ask polysubstance abusers who abuse 3, 4 or more substances, were you abused as a child? 90% say yes. Most children who are abused physically are abused by alcoholic or substance abusing parents. The 2 strongest predictors of childhood arrest are incarceration of a parent or other close relative or abuse in childhood. And in a California, Sacramento County study done by the Child Welfare League, they looked at 75,000 12-year-old children. And they found 1,000 who had been identified as abused or neglected, and 50% of them had been arrested. High correlation between child abuse and neglect and arrest. If you add those 2 correlations, the risk of being incarcerated if you have a relative in jail or prison, and if you're abused or neglected, you can see that what we have developed is a pump to build this population on and on. Meanwhile, we now have data from the National Comorbidity Survey that tells us, if we want to know about people who have both a substance and a mental health problem, that the country has about 10 million people who, if they were examined today, have at least 1 mental disorder and 1 substance abuse disorder. And the median age at which 90% of them had their mental disorder first. Only 10% developed their substance abuse disorder first, if you ever wanted to know which came first. And the median age at which the person could have been identified as having a mental disorder or an emotional disorder of consequence is 11. Again, we have a child population of abused, neglected kids whose parents are already in the criminal justice system, abusing drugs or mentally ill or both, that become a social pump, that are building this system, and we are simply responding by building beds for prisons. We have a tremendous interest in early treatment of children with mental disorders as the best way we can think of to avoid drug abuse. As the chair of the subcommittee on dual disorders, MICA patients for the Substance Abuse Mental Health Services Administration in Washington, I have been pushing for 5 years not only to get the book published, but to get a national initiative on dealing with emotionally troubled children as a way of preventing substance abuse. And we're just beginning to get underway in Washington. I wonder if New York State has any interest in that. DARE is wonderful. There are graduations. Kids like it. Families like it. The data show that it doesn't particularly prevent substance abuse. Here is a way of taking a targeted population, very high-risk population, and paying attention to kids who are already emotionally disturbed at an early age and dealing with them. Why is it important? Well, if a person has one mental or drug disorder, they're going to be unhappy, but they can have a life. If they have two disorders, they're not going to be able to keep that life going on a steady basis. And by the time they have three, they're in public institutional care. They're disabled. Disability is correlated much more with the number of disorders than with any particular disorder. In my practice, I treat people with schizophrenia and bipolar illness who practice law, who drive school buses, who teach school. They have one disorder, they're in a rehab program, they're in care, and they avoid the second and the third disorder that would disable them. We need a public health approach to mental disorders and substance abuse if we want to help people. The single commonest cause of psychiatric relapse in this 10 million population is drug use. The single commonest cause in this population of 10 million of cause of relapse to drugs is untreated depression and untreated anxiety, unless we treat both. In the prison or wherever they are, we end up with multiple problems. Now, there's been a long debate about how effective is treatment in prisons and jails, and the best study we have is the Institute of Medicine study, the distinguished group in Washington that does very detailed studies, and they found that most programs don't work, but that therapeutic communities and similar in-prison residential programs reduce rearrest. Reduce rearrest by 25 to 50%. And Steve Amos, the Justice Department, spoke at a meeting I was at last week in Washington, and he said with pride and embarrassment that there are 20,000 treatment slots in the nation's prison system. 20,000 for the million prisoners who need them. And for those of you who think that with 3 strikes and you're in, our communities are protected, the release rate from the 2 million cells is 460,000 a year coming back to community. So treatment works, but we're not doing it. And meanwhile, we've seen this tremendous increase in the jail and prison population while we've lost our beds. Some estimates are that 80% of the incarcerated are diagnosed with at least a personality disorder, if not a serious mental illness. And of that group, 80% of the prison population have a drug or alcohol problem. So mental health treatment in the prisons isn't enough. Drug abuse treatment isn't enough. We need to address both problems if we're not going to have relapses. There are virtually no services in the prisons for such people. There's been a lot of talk about violence and Kendra's law and the mentally ill. The National Health Policy Forum is about to put on a forum in Washington. Paul might be interested in that, on Kendra's law and the Maryland decision. The state of Maryland decided not to do involuntary community commitment, but to focus on providing services instead. I sit on the board of Pathways to Housing, a New York City agency which houses about 300 homeless, mentally ill people. We had a board meeting last night. 88% of the people we offer shelter to, offer housing to, and then provide services to with an ACT team, stay in the program. Our retention rate is double that of traditional residential programs that say, if you're clean and dry and you take your medicine, you can have an apartment or a room. The Pathways approach is the exact opposite of Kendra's law, and it's working. So we really need to go beyond simply pandering to public fears and provide services. The consequence of all of this now is that when I address audiences in the criminal justice system, I start with this. Congratulations, you are now, pick your title, Warden, Chief of Security, or Corrections Officer. You are now the warden of a mental hospital full of drug addicts. That's our prison system today. That's our jail today. High risk of suicide, violence, all kinds of things. The kinds of things that Joe started us off with. Just a way of sorting it out before I stop. We do know that professional criminals, now let's go back to the 200,000 to 2 million for a minute. Either we've had a 10-fold increase in true criminality in the United States in 30 years, or something else is filling up our jails and prisons, mostly nonviolent, mentally ill addicts. There are professional criminals, the true sociopaths or antisocial personality individuals who use drugs to give themselves courage to commit a crime, but the culprit is not the drug abuse or the mental illness. There are substance abusers who commit crimes to get money for drugs, and one can see that as a substance abuse-induced crime. There are substance abusers who are not mentally ill, but they may have a violent, organically induced psychosis, like a crack addict who goes into a bodega and shoots everybody in the place. There, although it will be spoken of as a mentally ill person, it's really a substance abuse-induced crime. Bad rap. Then there are sane criminals who, after they're apprehended, may feign or pretend to be mentally ill. And again, there's a bad rap on the mentally ill if that works. And then there are mentally ill people who may self-medicate to deal with their mental disorder, and the substance abuse may lead to disinhibition or crime, or there may be an increase in persecutory paranoid thinking because of the drug abuse and the mental illness together. And there, the mental illness is primary and the substance abuse is facilitating or secondary. But as a judge sits on the bench, I'd be interested in Judge Walkman's reaction to how well and how much time a judge has to sort this out, and how much help he or she has from probation or whoever did the pre-sentence to try to figure out what's primary, what's secondary, what's needed to protect the individual, and what's needed to protect the community. In closing, I try to show you my social map. We have separate budgets, separate systems, separate licensing for mental health facilities, for health facilities, for substance abuse facilities, all of these horizontal lines. And the problem is that we need vertical integration among the systems. When we look at the beginning of the chart where I have crisis or relapse, we do pretty well if somebody gets to a general hospital emergency room psychotic, because there is security there, there is somebody to do a mental health evaluation, a medical evaluation. We do pretty well in the crisis. That's where we put all our money. But as the person begins to recover and moves to the right on this chart, our system of integrated efforts falls apart. And every system's on their own. And that's where we lose the client and we end up with the repeaters. Thank you very much.
Thank you, Doctor. Our next speaker is probably someone who needs no introduction, but I have to say something anyway. Saul Walker is the former Chief Judge of the state of New York, who I have had the benefit in probably the last 2 years of experiencing his guidance and understanding of the mental health system and many of the things that our organization is doing today would not be possible without his assistance. His bio talks about his own experience, which I'm sure he can do much better than I will. But he has become a leader in the community for people who have not had the kind of voice and representation that the judge's involvement in this issue brings. And we know that he does it at some level of personal pain because he has lived it. And I can only minimally understand how he feels. as we're working on these issues in the halls of the legislature and the Capitol, trying to get people to talk about people living with mental illnesses who are in jail, and you frequently feel like you're trying to sell used shoes. It's not a sympathetic constituency, but we do have an individual in Judge Wackler who has been willing to make the sacrifice and to talk about his own personal experience, and I'd like to introduce and welcome Saul Wackler. Thank you.
Thank you very much, Joe, and thank you very much for hosting, along with others, this meeting to address a topic which is generally not very popular. There's not much of a constituency for change or for doing anything about the problems we look at today. Someone, Brennan, was talking earlier today, and he said that he's very interested in this and does what he can, and I said to him, well, it's not as if there's a great constituency out there to vote for someone or to work for someone who expresses an interest in this subject. I hate being there. I hate talking about this because I have to preface it by saying what everyone knows, that I was in prison. And that's something that no one can be proud of. I recall when I got out of prison, I had two choices. I could have either written a book or become mayor of Washington, D.C. And I decided to write a book, and I had much more luck than you, Dr. Pepper, because, in fact, if you had gone to prison, your book would have been published much more quickly, and you would have sold a lot of copies of it. But in that book, I tried to describe some of the things that we're talking about today. What Dr. Pepper has said, and Senator Abate and Dr. Bruno will tell you, is something they know much more about than I do. I have known some of these things, but I've learned them very late in my life. The last time I was in this room, as a matter of fact, was 15 years ago, when I was being confirmed as Chief Judge of the state. And to come here now in this situation brings a stark reality to my situation. We're not here talking about guilt or innocence in the criminal justice system. There's a story told in ancient Yiddish law about a village of Chelm where all the fools lived. And the rabbi from Chelm was going to go out and decide how to build a prison facility in his village. And he went out to other villages and canvassed the population of the prisons. And he came to the conclusion that half the people he spoke to were innocent and half were guilty. That's what they told him. So he decided in Helm that he would build two prisons, one for the guilty people and one for the innocent people. The fact is that we start with the premise that the people in prisons have violated the law, that they are guilty of committing a crime. And then we come to the dichotomy, the distinction between, or the incompatibility really, between the law and psychiatry. The law being concerned with, did he or she do the wrongful act, and the mental health disciplines determining why this person acted the way he did and what can we do about this. Unfortunately, the mental health professionals have not won out. The law developed its first definition of a word which psychiatrists or psychologists will never use, the word insanity, from an early case back in 1843, where a fellow was beset with what we would now call paranoia. He was convinced that the Prime Minister of England was out to get him personally. And so he went all over Europe, dodging shadows and trying to escape this Prime Minister who was going to kill him. And finally he decided that he would take the law into his own hands and he would kill the Prime Minister. So he went to number 10 Downing Street. He waited for the Prime Minister, Robert Peel, to walk out, and then he shot him dead. Of course, it was a very bad day, not for Robert Peel, but for Robert Peel's secretary, because the assassin killed the wrong man. The assassin's name was David McNaughton, And from that, we formed the McNaughton Rule. The McNaughton Rule, which said, at the time of committing the act, the accused was laboring under such a defect of reason from a disease of the mind as not to know the nature and quality of the act he was doing, or if he did know it, that he did not know that what he was doing was wrong. 1843, that was formulated. That is still the law. Or the Model Penal Code has suggested variations of it with respect to substantial appreciation and so forth. But after the Hinckley shooting, we came back to the other definition. So the law doesn't recognize gradations of mental illness. It cannot draw the distinctions that Dr. Pepper spoke of. Judges don't know the difference by and large. They know the McNaughton Rule. And we saw this demonstrated very recently in the trial of the murderer or the accused and found murderer of Kendra Webdale, Andrew Goldstein. And the conclusion was that because he knew what he was doing was wrong, he said that when he pushed her from the subway platform, that he was guilty of murder. And the jury found that he was guilty of murder. Forget the fact that he was a known schizophrenic, that he was hospitalized for that he was under treatment for that he had not taken his medication, although prescribed. Forget all of those things. He was guilty of murder. How could the jury find him guilty of murder? They found him guilty of murder because he was guilty of murder under New York law. And that being the law, it's little wonder that we have so many people, and Joe gave you the figures earlier, so many people who are mentally ill in our prisons. Mentally ill, not insane under the legal definition, but mentally ill for any number of reasons and any number of maladies of mental illness. And the judges are not able to draw distinctions. In my case, the judge said from the bench, I think there's no question, but that this man was mentally ill. But, she said, I don't know how a person who is mentally ill can function in another job, in a demanding job, and do it relatively well, which shows that the judge had absolutely no knowledge of what we know to be bipolar disorder. Or, as Dr. Pepper amply described it, someone who is mentally ill and then tries to self-medicate, and then by virtue of that self-medication kicks into delusional behavior. This is something that was unknown, certainly to her. And so, it becomes a question of education of the judges. And we've now started at the health system in which I'm affiliated, the Law and Psychiatry Institute, trying to become as good as the one operated in George Mason University by Mr. Stavis, where we are now, through an arrangement with the Office of Court Administration, this summer, going to teach the judges of the state of New York, having psychiatrists and psychologists speak to them to educate them with respect to the manifestations of mental illness so that they will understand. And we are now going to start an experiment. John Feinblatt of the Office of Court Innovation worked with me when I was chief judge in establishing the community court in Manhattan. We had the idea of a multi-doored courthouse where, because we have our hands on someone who has committed a crime, we could direct that someone, by virtue of the male fist in the velvet glove, to treatment or to some other alternative form of punishment, rather than put the person in prison. And from this sprung the drug courts, which Judge Kay innovated when she became chief judge. And I've spoken to her about mental health courts, and I also spoke to her along the lines that Dr. Pepper referred to, the fact that these should be consolidated. They should be alternative treatment courts, so that when people come through this process, they can be directed to treatment for the addiction and the mental illness, which we find, as Dr. Pepper said, go so closely hand in glove. These are the things we're working with. The first court that we'll be establishing will be in Kings County very soon, again with the Office of Court Administration. And we're very excited about this because we are now reaching the point where we realize the enormous populations in our prison of those who are mentally ill. And we know, and I know from very personal experience, that these people do not receive treatment. I tell you that when I first went to prison, if it hadn't been for the fact that I was in home confinement for a year under psychiatric treatment, if I had gone directly into prison, into the mental health unit to which I was sent, I would have been totally dysfunctional today. Because the first thing they do is put you in solitary confinement to observe you. Now you take someone who is mentally ill and you put them in solitary confinement in a mental health unit so that the other people in the other cells are also mentally ill, screaming all night long, having delusional experiences, and not being treated by a physician or a psychiatrist. And I tell you that if you're not mentally ill, when you go in, you certainly will be mentally ill shortly thereafter. And then go into the mental health unit where I went and see the three modes of treatment. One, you have a group of prisoners doing what they call a Haldol strut. They give them Haldol and they walk stiff-legged through the units. Or others who do the Thorazine shuffle. They get up in the morning, they give them Thorazine so they can be zombieized. And they walk around all day long in that fashion, waiting in line to get their medication. That's how they spend their day. Therapy, I saw a psychiatrist once while I was there. His name was Dr. Herbal, or Herbal. And he said to me, I'll never forget the session. He said, did you read the book of Job? I said, yes. He said, I want you to go back and read it again, and then we want to talk about it. And I went back and I read it again, but he never saw me again. So I don't know what he wanted to tell me, or what he wanted to learn from me, or what he wanted to teach me, or what kind of therapy he wanted to administer. I saw no other psychiatrist. And then I was stabbed in the mental health unit and put in chains and sent to another mental health hospital in Rochester, Minnesota. They have 3 of them in the federal system. The third method of treatment is what they call diesel therapy, where they take a group of prisoners, they treat them for some months on these medications which don't bring about cure but simply neutralize or immobilize the prisoner. And then after some months they put them in buses and they send them to another mental health hospital where they spend some months being treated the same way, and then they're put in buses and sent to other mental health hospitals. And after they go through this routine for some 4 or 5 years, and then discharged, jettisoned out on the street and meeting the fate that Dr. Pepper showed you. So many of them on the streets today, wandering around, not being treated. If they were treated in prison, well, we saw the empirical data. This would be so meaningful, and you have them. You have them. You can administer this treatment. But instead, people, again, people in public office recognizing there's no great constituency for this, would rather talk about longer sentences and making hard time harder than talking about trying to do something with these people who, again, will one day be out on the street, committing more crimes, destroying more lives, and particularly their own. So this is what we talk about, and this is what we have to concern ourselves with, and this is what we have to do in order to remedy a situation which we should remedy, if not for our own protection, and that's part of it, then because we are a civilized nation who concern ourselves, or should concern ourselves, with the human condition. Thank you very much.
Thank you, Judge. Our next speaker is Nahama Bonner, who is a psychologist and has a very, very strong background in the issues of diversion. My first contact with Nahama was when we started working on this issue earlier, and I called her and she said those 4 words that every advocate wants to hear: how can I help? This is the answer to the question. Thank you very much, Nahama, for joining us.
It's a honor to be here, and it's an extraordinary honor to sit with the three of you. I'm going to talk about a few different things, and I was asked to focus on models of diversion as well as research. Now, I can shout if not, if this doesn't work in the end. I don't know if I'm going to be able to do all this. I'm going to start with talking a little bit about diversion and sort of general setting the framework. We've already really begun to hear the numbers, so I'm not going to sort of go through all of the numbers nationally or locally, but I do want you to sort of keep in mind as we start to move into the data that in the city there's an estimated or guesstimated 135,000 people annually cycling through our city jails in Rikers Island and its associated borough houses, of which estimates range from 15 to 20% have a mental health disorder. It's going to be important as we go through this because what we're seeing may indeed be a bit higher. But let's first start with sort of diversion. There are a couple of, too basic at the moment. Researchers are sort of divvying up diversion to pre-booking models and post-booking models. The pre-booking models is when somebody is, before they are arrested, that they are given some other kind of disposition other than arrest. And many of the models that exist are sort of hospital-centric, that a person is taken to a hospital. Some models have aftercare attached to that, some don't. But a primary locus is with the police department and the policemen. Dean Stedman, Warren Vesey, and Morrissey did a comprehensive study, and this group has sort of, with various authors, has done the major work on diversion. They looked at and surveyed 3 types of police diversion or pre-booking models. One that's sort of police-based, in which there's a specialized police response, in which the actual police officers have training. For instance, the CIT model in Memphis that's being replicated in Portland, in Seattle, and I think there's a site in California as well as elsewhere. There's also police-based specialized mental health response, so that there are mental health people, professionals who are working with the police. And there is the mental health-based, sort of specialized mental health response, in which it's really a separate agency that then coordinates or somehow, either formally or informally, works with the police department. So there are a number of templates around the country, whether it's Los Angeles, whether it's the Memphis model, New Orleans has a model, but New York does not. New York certainly has training. New York certainly has informal diversion in terms of a pre-booking, but there is no pre-booking diversion. And part of the theme of this, and as we, I hope one of the points I'll be able to make to you is that with the cycling of people, just as Dr. Pepper talked about the need to intervene early, I will also talk to you about if we're already on an intervention mode in dealing with adults who are already multiply wounded and in multiple sort of disorders and in crisis, that you need to intervene at multiple points along the continuum, from pre-arrest all the way to the back end on discharge planning. The post-booking, do this, which is after arrest, again has a variety of models. Stedman focused on how to begin to describe what is a diversion program, and that you had to at least minimally have screening, evaluation, and negotiation as components. And with that, they surveyed 760 jails, coming up with about 18% actually had these programs, only 50 programs around the country. Interestingly, and I think in the last few years, since the study's been published, there's been a proliferation of these kinds of programs. And the post-booking programs are divided, again, even further in a number of ways. Those include the mental health courts that people are beginning to talk about here today and obviously elsewhere, that are sort of based on the sort of Boston treatment drug court model. The court model includes the intensive case management model, which is sort of is similar to the task model that was developed in the 70s, again, a drug-based model. And currently across the country, there are several places, including in New York, in which there's the focus beginning on planning and starting mental health courts or mental health case management. The other kind of post-booking diversion is from jail. And actually, to back up one moment, the court model can occur along the continuum. There are models in Connecticut at arraignment court. There are other models around the country at criminal court or the felony waiver part. Another type of post-booking diversion, of course, is jail diversion. That's one of the things that we're looking at in New York, at NYU, and as part of the SAMHSA Jail Diversion Initiative. We're looking at New York City's Department of Mental Health, New York City Link, and their response to and what is this kind of post-booking jail diversion. To borrow from Policy Research Associates and Gates Center, where we have Collie Brandon here, their work and with the lead of Hank Stedman nicely just modeled this out so that you can see that pre-booking includes police, emergency room, mobile crisis centers. Again, this is happening throughout the country. We don't yet have this here, and so that needs to be a focus. Post-booking, pre-arraignment. Judge Walkler mentioned that there is going to be some response beginning in Brooklyn. There is the OCA's initiative. There is also an arraignment evening, sort of arraignment mental health services starting. There is in the Bronx a planning grant for Bronx court-based, but this is very new, and there isn't anything yet operational, and that's important to remember that, again, we don't have much going yet in terms of either pre-arraignment or anything that's court-based. And then there's post-arraignment, which includes both jail, courts, probation, and community service providers. Now, this was going to be conclusion, but I've moved them up to talk about this actually now before I get into sort of individual clients. I want to talk a little bit about some of the elements that are helpful in terms of what we're proposing may be useful and successful diversion programs. Now, it's important to remember that there is very little work done on actually evaluating diversion and describing what that is. That is why Congress funded SAMHSA under CMHS and CSAT with Gaines as the technical assistants and Research Triangle Institute as a coordinating center. That's why they funded 9 sites around the country to look at different models of diversion. Each site is doing something very differently, from pre-booking to post-booking, with linkages into the community and without linkages. So what is being presented is preliminary and it's proposed, because we don't actually know empirically yet what works and what doesn't. We will have 3-month follow-up data across the country in September and year data next summer. So we really don't yet know. This is all preliminary. So but as we're working with multiple sites around the country, and as I'm working here with multiple stakeholders and shareholders, what seems to be needed for diversion programs is you have to know your population. You have to decide who it is you're going to treat. You have to decide whether or not this is mentally ill persons, whether this is co-occurring, whether this is a combination, whether this is personality disorders. You need to know. It has to be specific. You also have to know, that's from the mental health end. You also have to know from the criminal justice end what charge levels you're looking at, offense type, etc. You need to define your diversion point. You can't talk about continuum. That's a complicated system to build. That's what we're trying to do in New York. We'll see how that succeeds. But you need to talk about which point in the continuum, whether you're going to build something at arraignment, criminal court, felony waiver part, and how they're going to connect to each other if you build bits and pieces at different points in the process. You need dedicated staff. It can't just be putting a staff member and saying, oh, that's diversion. You need defined, trained diversion staff that are dedicated to this kind of program. And one of the things that I'm not seeing frequently, and is certainly, I think, the case in Connecticut, is most programs don't seem to be model-driven in terms of their diversion staff. That needs to be linked to, you need to have an idea. Is this intensive case management, and what kind? Is this an ACT team model? So I think that one of the things that's going to be very important is that whatever we're doing, it needs to have a foundation to it. And that sort of is similar as you begin to talk about staff training, that if you have a clear sense of your population, then even though you're just doing case management, for instance, in diversion, that needs to have an understanding of your population. So that may be trauma training and the latest work that's done there, or integrated treatment, not just sort of the idea that somebody's getting a little bit of each, but actual integrated treatment. The staff needs to be cross-trained, multidisciplinary, multicultural, multilingual. That's actually something that I've seen in many staffs, including in the city and up here and elsewhere. That is something that actually people seem to be doing very well. The supervisory staff, there needs to be what Dr. Steffen calls a boundary spanner, somebody who's multiply trained in different areas who can help sort of bridge. But you also need, which many programs don't have, a true clinical director. Somebody who really, because even though people are talking about sort of moving somebody through a system and linking them, understanding what the issues are, understanding and being able to help the person move through these issues needs clinical underpinning, and the staff needs to be able to be aware of these issues, or it becomes tremendously frustrating for them, and burnout occurs. Consumer recipient involvement. This is, very much pressed from the federal agenda now, and there are really extraordinary resources and models for involving consumers as your staff, on your advisory boards, in peer groups, at all levels. All the instruments that we've been developing are done with a panel of consumers who review them and pilot them prior to our using them. There has to be aggressive, systematic case finding and referral system. That's extremely important. Screening and assessment that's standardized. Policy and procedures so people can replicate, so they know what they're doing. Reduction in the usual jail time. That has to be an immediate consequence of diverting, otherwise you're not diverting. And you're not diverting in a mental health context unless you're diverting to something. It's not, we're not lawyers. We're not just diverting from. We have to be diverting to if you're going to create a diversion program that focuses on this population. So the linkages have to be treatment-focused as well as multiple needs-focused. The other piece that's needed in terms of setting up these kinds of programs is an infrastructure. And funding and resources for infrastructure development will probably go a long way. There needs to be constant and regular key stakeholder and shareholder meetings. This is very complicated work with multiple systems, and there needs to be ongoing stakeholder investment in it. There needs to to be ongoing staff and cross-training between the systems. There needs to be management information systems. People here cringe often because of what that may imply, but there are systems not only out there that are voluntary and with a full informed consent and differentially give data to different agencies at the client's request and only with their explicit permission. But there are systems throughout the country that are non-proprietary and free that are being used. And the reason for that is we have to find a way to not lose all of the information that we gather for our clients. We have to find a way to maintain continuity of care. We have to find a way to, in this kind of complicated system, have some quality assurance and be responsible and have data. You need to have evaluation. People need to see what you're doing and what's working and what's not, and it should be able to be a program that evolves. This is still very new and needs to be worked with further. There needs to be mechanisms for seamless referrals, housing. This is all things that all of you know already. Continuity of benefits, medication, medical care, child care, legal resources, clubhouses, psychosocial, social, and of course, my focus here today is not on integrated treatment, that's another talk, but that isn't just lip service. I think we were at the Gaines conference with Joe Morrissey, who's took the lead on developing a instrument that's sort of looking at integrated treatment on a management level at programs. And we were talking about that one of the things that has happened is that the word integrated treatment has been disseminated beautifully. Everybody raises their hand, yeah, we do integrated treatment. But very few people are actually doing integrated treatment. And why that's so important and why you're probably hearing those buzzwords is that you're talking about a difference between 10, 15% maybe success versus 60% success. Yes, people can't survive without a house and without that stability and without food and without medicine. On the other hand, they also will lose all of that if they keep receiving treatment that is damaging and inappropriate and sort of destroys both them sort of neurologically as well as their sense of selves. So from that, I'm going to now talk a little bit about some very preliminary descriptive data on both some jail clients and pre-arraignment clients. Hurry this along. And I'm doing this because I thought, let's keep it local and let's sort of put a face on some of the multiple needs, because you keep hearing about multiple needs, but I've sort of wanted you to sort of hear it from the clients themselves. I've combined two studies here. One study is the SAMHSA Jail Diversion Initiative, which I talked about. These are very preliminary, early numbers. It's not the complete study. About 100, and this green box represents about 150 people. There were no differences between our comparison group and our experimental group, which is a diverted group, and therefore I'm presenting it as one block for the demographics because they were in essence the same. The second study, which I've sort of put on here, which I'm going to talk about, is a pre-arraignment study of the evening court in Brooklyn, in which again it's just a touch in the, considering the numbers. But we looked at 312 randomly selected pre-arraignment detainees prior to them seeing the judge, of which about 50% overall of that population gets released onto the street. The other ends up in our jail system. And we also looked at what are called EDPs, emotionally disturbed persons, a small sample of 40 people in which they had been designated and brought in by police, viewed with charges serious enough to arrest them and to bring them in to be arraigned. So we looked at those two groups. Again, one is a random group, and why that's important for you to keep in mind is you will see rates of mental health problems and serious diagnoses that allegedly, according to others, you shouldn't see in just sort of your regular jail population or your regular, man on the street population that gets arrested. So this is just a quick, I'm going to run through very quickly some of the demographics. Not surprising, as in the literature, the mentally ill and the severely mentally ill are at a mean age in the low to mid 30s, whereas the rest of the population is younger. Just so again you have a sense of who we're looking at. We're looking at a, not only speaks to the who we have in our jail system and who we have who are also with mental health problems, but it also gives you a sense that we are looking at people who are white, black, Hispanic, Asian, Indian, American Indian. Just race through some of these and spend some more time on the interesting ones. Gender, again, this is just to show you in the system, and I think I may stand corrected, I think it's maybe 20% or even less female. In the mental health system, it's higher. In our sample, it's quite high. The one good piece of that is that we're able to then really look at what the women look like. And we administered a whole series of measures on psychiatric symptoms and diagnosis, substance use and housing and psychosocial needs, etc. Educational level of the random sample is higher. This includes people who do not have mental health problems. It's about 13.6. Both the emotionally disturbed population, which is the EDP designated population, not a term I love, as well as the jail-based, severely and persistently mentally ill population we looked at have lower education. And when we actually compared this across the country, we were the lowest. And what that does is it begins to build a story, because as we go along, you will see more homelessness, less education, less work, more ACS involvement, and so forth. Quickly, top legal charges for, this is, again, the jail detainees. Can't generalize across all detainees. This is a severely and persistently substance abusing sample. You see that about 10% have crimes against persons that are being, and this includes people who are being diverted, about 4.5 of other crimes against persons that are nonviolent, property crimes. The highest is the drug crimes, and again, about 9 sites around the country, we were again the highest in terms of drug crimes, and then minor offenses is actually fairly low compared to the rest of the country of who's being diverted. We seem to actually be diverting a more serious population in New York. The jail detainees, in terms of priors, again, and to one more time put this in context, these are people that have a psychiatric and a psychiatric diagnosis that's then been confirmed on structured testing of schizophrenia, major depression, or manic depression. So we're really talking about and who have been actively presenting with symptoms within 2 months of the interviews. You can see that this population has, no surprise to anybody, high level of prior arrests and convictions. In terms of the pre-arraignment detainees, the blue box is the random sample, a little bit higher. Makes sense because we were looking at the only exclusion that we made is that we did not see anybody who had been charged with murder on the study, because although we had all the consents, we were concerned that that could possibly be used in the capital case, so we excluded them from the study. So a pretty fair distribution with drugs, again, as very high. This is beginning to get more interesting. What this shows you, and I know it's sort of complicated to look at here, the EDP arrests, the blue all the way across means that these groups did not have either misdemeanor convictions, felony convictions, etc. The second bar lets you know that that's 1 to 4 times, and the beige bar is 5 or more. So the EDP group is clearly arrested. 50% of them were being arrested 5 or more times, of which 67% had 5 or more misdemeanor convictions, of which 10% had 5 or more felony convictions. So sort of giving you a sense of, it's not just, when we start to talk about when you intervene in the system, yes, it's great to do felony diversion programs, and it's great to do arraignment diversion programs, because the truth is that most of this population, whether it's even in the random sample or it's in the police designated sample, have gone through the system multiple times. And if you can save that even on a 6-month period of time, imagine both for their lives, let alone the financial savings. It's just quickly to show you, no surprise here, large proportions of people are serving time. Quickly, just switch this actually. I want to show you something else, because often in these conversations, because people get overwhelmed by the complexity of the system, we don't talk about all the systems involved. This is also, you should note that that ACS is an agency that would probably need to be involved in any kinds of planning that's going to have to do. This is both men and women are losing custody, are having ACS involvement. Skip employment. Government. About 70% are on government assistance of the random sample, with about 80% of the mental health sample. Sorry, can't find the slide. I just wanted to note this. About 55% of the EDPs had Medicaid or Medicare, and 40% of the random sample. That means 42% of those that were randomly looked at had absolutely no insurance. And 37% of the police-designated emotionally disturbed persons who had been in psychiatric hospitals and in recent care repeatedly had absolutely no insurance. Most of, about 70% of the emotionally disturbed persons admitted to past histories of homelessness. In terms of shelter living, 35% of the EDPs had all said they had recently been in a shelter, with 21% of randomly selected people also being in a shelter. Just quickly, sort of homelessness, they did not, most people did not want to admit to current homelessness, and they didn't count shelter, living in car, or living with friends or family from night to night as homeless. They counted that as being domiciled. Okay. Start to finish up. In terms of mental health, quickly, so that sort of begins to paint a picture of the homelessness, of the psychosocial status of a population that is in multiple need, as each person is saying. When we start to look at diagnosis, one of the things that struck me the most was that when we did this random sample, and again it's small, it's 312 people, but each of whom sat for an hour and a half interview, that when we looked at this, 26% demonstrated a mental health disorder that was serious enough to reach full criteria of either schizophrenia, major depression, bipolar disorder, and we also included post-traumatic stress disorder and generalized anxiety disorder. And that did not include anybody that just had symptoms, difficulties. They had to reach above criteria on all standardized tests. Those numbers were slightly higher when they were independently interviewed by clinicians, and we went with a conservative figure. I think that that's important to keep in mind when you are thinking about the numbers of people that are coming in just to, sort of in Brooklyn, in arraignment, 100,000 arraignments in a year, to think that 26% of people who are not being screened, not being looked at, not being treated, not being case fined, are actually either moving back to the street at that point or going into jails, most likely into GP. None of these people had ever volunteered or noted that they had mental health problems. Okay, just finish up. Most of these clients also had histories, as you can imagine, of hospitalizations, suicide attempts, and so forth. This is also no surprise because of what you had said, Dr. Pepper, but I just want to sort of again show it that the rates of violence and the experience of violence, whether it's physical, sexual, emotional, and being victimized, are extremely high across our baseline population, which really gives you a sense of sort of where we're headed to. And then you combine that kind of abuse with people who are also being victimized as adults on top of their childhood victimization secondary to their illness. Okay, I need to finish up. What I'm not going to get to today, but I want to at least sort of tease you for another time, is where I was going to finish was in talking to you about what happened when we surveyed 65 policymakers, consumers, family members, judges, lawyers, and others about diversion. And it should be no surprise that from the highest level, commissioner levels, down to director levels, that it has been uniformly endorsed in terms of the interest in beginning to divert on a court-based level, that the issues of screening, the issues of cultural competency, the issues of aggressive case finding, the issues of funding, the issues of information management, all of these have come to the surface as being important facilitators and barriers. And so on that note, I thank you.
Our final speaker is Catherine Abate, who is presently the CEO of the Community Healthcare Network, and her bio has a number of formers in it, including former candidate for the New York State Attorney General, former New York State Senator, former Commissioner of the New York State Department of Corrections. Catherine is probably, unbeknownst to her, the genesis of this event. She and I met each other, or re-met each other about 2.5 months ago at an event that David Kellogg and I were at as well, and talked about this subject, and we walked away from there with the idea of saying, I think we need to have a public forum on the subject. If you have a chance to talk to the presenters, you will notice that their name tags all say presenter. That is also Catherine's fault, because as we went through her resume, we couldn't figure out which title she was supposed to get if we designated by title. So hence, all of our esteemed colleagues and speakers are in fact presenters. Without further ado, I'd like to introduce Catherine Abate.
I'm going to give you some highlights of my prepared remarks, but I want to thank Joe Glazer and the Mental Health Association for bringing these wonderful experts together, and for all of you caring enough to be here, but particularly I'd like to recognize Judge Wachtler. It's extraordinary, not only his life, I think he's one of the most amazing men in what he has contributed to jurisprudence, but the courage it takes to take what has happened in his life and become a major voice for change. And his voice really will be, in the future, one of the most powerful voices for people who are mentally ill in our jails and prisons who need treatment, and those of us who have worked in the criminal justice system that need leadership to make sure some of these changes occur. So congratulations and thank you, Judge. When I was listening to the panelists, I thought about an event in my life that occurred 30 years ago, and it's hard to believe that I did this, but it's an event that I believe does highlight the failings of the criminal justice system and their treatment of the mentally ill within that system. 30 years ago, I was a criminal defense attorney working at Legal Aid Society in New York City, very idealistic. The judge was very flexible. These facts that I present to you, it's unlikely that they would occur today. But I had a client, I was a young attorney, who was duly diagnosed substance abuser, chronic mental illness, a veteran, inconsequential criminal record, just underwent an enormous tragedy. I don't remember what the tragedy was, but he came before the court. I saw him in arraignments, and he was very sympathetic, and the judge wanted to keep him in because he didn't have a home, not unlike a situation that might occur today. And the judge says, well, I have to 7:30 him. We'll keep him in 30 days. And I said to the judge, this doesn't make sense. He's not at risk. I think it was even such a minor crime. I said, can't we do something? I called the veteran hospital. They wouldn't take him. I finally went to a colleague lawyer. I said, would you come with me? I mean, this is maybe a little bit absurd. If I can get the judge to have this client release him to my custody, I'll put him in my car with my colleague at the Legal Aid Society. We're going to drive my client to Mid-Hudson. We're going to knock on Mid-Hudson's door and say, would you take this person for residential treatment? Well, I did this. I got the judge. We had a picnic along the way because we had to stop to get some food. This is a true story. I knocked on the door and they said, no, we can't take him. So I then had to drive back in the middle of the night, get him back into the custody. I got him back into arraignments. Doctor, is that a real story back in the 70s?
Sure.
And so I never dreamed 30 years later or 20 years later I would be the commissioner of probation and then commissioner of correction running Rikers Island in the jail system. And I have to say, even after those experiences, I have a great understanding of the problems. I can't say that was even part of the solution. There's so much that needs to be done. Every expert in the area knows that more has to be done. There hasn't been a political will or public service will to bring all the players together to make sure, and the money that's needed to make sure the changes have occurred. We've heard about the crises in jails and prisons for many, many years. The discussion has been around overcrowding and TB and AIDS epidemics and violence, but very little attention has been played to the increasing number of mentally ill in jails, the lack of adequate treatment, and the full knowledge we all have that jails have become the repository for the mentally ill in our communities. When I became Correction Commissioner after probation, this was in 1992, for 2 years. Most of the people with mental health needs were misdemeanors in the system. I'm told today that has changed. There are more and more people in the jail system charged with violent and serious crimes. Today, at Rikers Island and the New York City jail system, in calendar year 1999, there were 219,000 mental health contacts from individuals with adjustment disorders to chronic psychotic illnesses. The average age was 31. As you saw from the charts, many of the individuals had prior contacts with the jail system and the criminal justice system. But the one thing that has not changed is that the same conditions that existed when I was there exist today, that the conditions in jail make it very, very difficult to provide the kind of care many of these individuals need. One of the reasons is the inmates are in constant flux, particularly in a jail system. They're moving in and out. In New York City, there are 126,000 new admissions a year. 25% of those admissions are in need of mental health services, and these individuals are moved to housing areas, to other housing areas, from one facility to another, to court and back to a facility, to hospitals, then back to court and back to jail. The mission of the jails is one of custody and control primarily, and third, it's care. Security concerns often outweigh the concerns around care, and necessarily so if you're a correction officer. It's about preventing escapes, reducing violence, intercepting contraband. The typical levels of care in the jail system are fourfold general population. That's where many of the people who have mental health problems are. And then if someone is perceived to have, and again perceived, because there are many people with mental health problems in jail not diagnosed, but if individuals are perceived to have a problem, then they're moved to a mental observation bed, where inmates often become the observation aides. They're trained to see if in fact there are suicidal problems. But these are areas where there's really not treatment. It's a pharmaceutical model, and people receive medication 1 or 2 times a day. And then if there's a sense that someone does require supervision and treatment, there are a few beds, and I'm talking about 368 beds, in a system where there are 126,000 admissions a year. 25% of those individuals need mental health treatment. There are only 368 subacute beds, where you're talking about 24-hour care and supervision. And then the fourth level of care is inpatient hospitalization, and that's the acute care beds. And in New York City, we're talking about 40 beds at Bellevue, 45 beds at Kings County, 14 beds at Elmhurst. So this is not a solution that provides comprehensive care to all the people that need it. So there's no wonder that the advocates say that if someone who's in need of treatment goes to jail, basically the solution is warehousing. There is no surprise when correction professionals say themselves this is too difficult for them to do, that jail is not an appropriate setting for dealing with these issues, particularly in a jail setting where there's great depression, stress of incarceration, suicide attempts, withdrawal for substance abuse, TB, and AIDS. Advocates recently have brought correction to court, and through Brad H., there will be more discharge planning, but everyone knew that correction didn't have the money, the wherewithal to do discharge planning. Judges, probation, district attorneys, defense attorneys have complained since I know, and I've been involved in the system decades, that they have no choice but to send people to jail because there are no community solutions. That when they're faced with an individual who's homeless and has mental health problems and substance abuse problems, they can't send them out into the community unsupervised. And so what happens, bail is set, detention occurs, and then incarceration. So now we have to ask, if we know all this, and that jail has become the primary provider of care for the mentally ill, and particularly the mentally ill or homeless, what are we going to do about it? And I want to spend 2 or 3 minutes talking about the solutions. Do I have a couple more minutes? Okay. One, and I just want to reiterate and underscore what Dr. Broner said, is that there are individuals who can safely be diverted from the system, identified at arraignment and central booking, with case managers and psychiatric staff, and with the support and coordination, again, with the police, judge, prosecutors, defense attorneys, so that some of these individuals can be released and supervised and get the treatment they need. The good news is there is a coming together of the players of the system. There's a little money that has already been funded. CASES is one of the programs looking at targeting the population, pre-sentencing, working with probation to divert some of the individuals out of the system. The agency that I run, Community Health Care Network, recently received a contract from the Department of Probation to work with adolescents in their alternative detention program, their GIS program, to develop treatment plans for these individuals. A 5-team approach where there is an education specialist, a substance abuse specialist, a social worker, a psychiatrist or psychologist, a family advocate, a team approach doing the diagnosis and developing a treatment plan that could be handed over to the probation department and the probation officer so they have a better sense of how to treat that adolescent. For those incarcerated, obviously we need early diagnosis upon being taken into custody. Each individual should be given a suicide prevention assessment by a healthcare professional. There needs to be a diagnostic instrument assessment to be approved by the New York State Office of Mental Health. Treatment should be consistent with what they were receiving prior to arrest. If there are manifestations, the individual should be immediately transported to a healthcare facility. Again, the model should be a therapeutic community setting, not a pharmacological model where people just get medication. Minimal standards must be established on a residential program model. It must be a multidisciplinary approach. I want to underscore again the necessity for discharge planning, whether that's pre-release or discharge from incarceration, the need for intensive case management inside the jail, and when someone leaves the jail, continuum of care and treatment, training. How can you ask correction officers to be helpful to mental health staff? How can police be supportive, or probation, or anyone else in the criminal justice system, unless there is cross-training between law enforcement and mental health staff? Planning and budgeting should be done jointly. I know in a correction system, if you just give money to the health and mental health staff and don't jointly support correction, there are no correction officers who are going to be able to take those individuals from housing areas and get them to clinics. So there must be memorandum of understanding that detail the guidelines and responsibilities between OMH, OASIS, DCJS, Commission on Correction, the local jail system. Increased accountability and oversight is needed if we are going to bring about change. And that means an increased role of the New York State Office of Mental Health, working with the Commission of Correction, perhaps greater auditing by the Attorney General or the Comptroller to ensure compliance with the laws. There are some ideas that have come about talking about the creation of Board of Visitors, similar to one in the mental hygiene law that is now needed in psychiatric facilities. Should we replicate that kind of overview for our jails? Finally, we will not stop the cycle of violence and crime and neglect in our communities unless there is investment in our communities and early intervention, whether that is support of housing, case management and social services, day treatment, residential programs, group homes, self-help, and peer groups. The early intervention will make a difference from someone graduating on for needing more serious care and incarceration. So lastly, why should correction and law enforcement buy into this? Sharing joint responsibility with mental health making sure that they increase services within the jail system and without. The reason is it makes sense for them. Right now, jails administrators are exposed to litigation and liability. They know there's a problem. They don't have the wherewithal to solve the problem alone. They know that they have to improve the safety of inmates and staff. They need to reduce stress and violence and stabilize their jails. They need to be concerned about public safety and recidivism. The only way to save dollars, again, the difference between the cost of incarcerating someone at Rikers Island, which is $60,000 a year, and the cost of a shelter, I'm not sure, is that $20,000 a year, and the cost of supportive housing, which is $13,000 a year. They are aware of these costs. If we're going to save dollars and save lives, improve public safety, we must do it with a treatment, appropriate discharge planning, and community reinvestment. That's when we will end the cycle that is occurring today, and will we begin to solve the problem of homelessness, mental illness, and people going in and out of our jails. Thank you very much.
We will take a couple of questions from the audience. We do have a few minutes in which we can do that, and we'll probably have to cut that somewhat short. But before I do that, I just wanted to say how much I appreciate the great information and the wonderful presentations we have had today. We've heard an awful lot of talk about integration of services, and as I look around the room, there's another thought that comes to mind, and that is the thought of integration of advocacy. We have a broad base of the community here with us today, who I think all understand what the issues here are and what we need to do. And we look forward to working with all of you, both the people here and the people in the audience, to make the changes that are necessary. So thank you all very much, and also special thanks once again to David Kellogg, our Director of Public Policy, for pulling this together, David Hamilton at the New York State Catholic Conference, Bob Corliss at NAMI NIS, and Steve Madernis at CSEA for making this event possible and such a great success. Thank you, and we'll take any questions you may have. Alice.
In New York State, now we're continuing and increasing actually the use of solitary confinement and double cells, and there's been the great concern that this is certainly causing people to develop all kinds of mental health problems, as well as to exacerbate problems already exist. And these institutions are becoming so close, more than they've ever been. Is there some way that advocates can be involved in trying to deal with that problem? Because all the cells are now being built in New York State are double cells.
Would you like to close?
10 years ago, I did a 2-day training for the solitary confinement guards in the New York State prison system in order to comply with a federal court suit about that system. And to my dismay, my welcome to Attica to do a workshop for 200 men and guards was I wasn't given a PA system or a projector. I hope the attitude of the Department of Corrections has changed in the past 10 years. I don't know if it has. The American Association of Community Psychiatrists has an initiative nationally to look at the consequences of sensory deprivation/irritation, because this is not a quiet place to be, as Judge Walker pointed out. I spoke with the U.S. Department of Justice about this last week, and will be meeting with people in justice. They have just begun to realize that nationally a lot of the federal construction money for prisons has gone to build new supermax facilities, which are entirely solitary confinement facilities. That's why I think we have to put together, that's what we're building, and we're releasing 460,000 people a year to the community. Connect those two things. Who comes out of those facilities? I would be certain that my colleagues and I, the American Association of Community Psychiatrists, would work with any group in New York that wanted to create an initiative at this particular point.
I think one of the most important things to do in this regard is to educate the public with respect to what solitary confinement is. I wrote a decision, one of the first decisions I wrote when I was on the court, Wilkinson versus Skinner, where I was explaining what solitary confinement is and tried to understand it. Then, some 20 years later, I was in solitary confinement. Not only for the week that I described, but after being stabbed, I was put in for 30 days for my protection. And I have to tell you that after about 10 days, I lost all track of time. I started to hallucinate. It was an experience that is beyond measure. Now, if you said, well, dangerous people belong in solitary confinement to keep them isolated because they create problems, perhaps there's a legitimate argument to be made for that. But I saw solitary confinement being used without any due process safeguards by correction officials simply to get rid of troublesome people who are making too much noise, who are making fun of other guards, summarily saying, you've got 2 days or 2 weeks or a month in the hole, and being put in there, and there was no recourse. And we, again, who pride ourselves on being a civilized nation, should learn exactly what is happening there, and see to it that it doesn't happen unless it's absolutely essential for the security of the facility.
Thank you. Clarence? We'll have to make this the last question because several of us do have to go, but please.
Just want to make an observation. We've been talking a lot about the mentally ill winding up in jail and prisons, but I think one of the points that needs to be emphasized is within that prison structure, the place where you're going to find people mentally ill are in the locked segregation and disciplinary blocks, because the same problem that brought people into conflict with the law, get them into conflict with prison rules and jail rules. And in that context, there is no insanity offense for violation of the rules. And every prison, every jail that I've been in, you're going to find the vast majority of people with mental illness either undiagnosed or certainly untreated, either disciplinary blocks of those prisons. And the conditions of those places are the wildest you'll find in any kind of mental health facility anywhere in this country.
And that's why there has to be a recognition. They're called all different things. It could be called punitive segregation units or whatever, to understand that who you're placing in these units and why. And you can't use one universal model for every offender. There are different reasons why people infract. And if you put someone who needs mental health treatment in punitive segregation, as the judge said, you're just going to exacerbate that problem. You can only keep them so long in a detention facility, they're going to get out and present even greater problems to other inmates and to staff. So there needs to be a review of that model and make sure there's ongoing treatment and psychiatric care, even if someone has to be isolated for a period of time. But that does not happen. The treatment does not occur.
That observation, in fact, is supported by the DOJ report that came out last year that says that people living with mental illnesses serve the greater part of their sentence and serve harder time than anybody else in the system. So I think that your observation is very well taken. Again, thank you all very much for joining us today, and again, thank you to our wonderful presenters. I'm sure we'll be working together in the future. Thank you.